to the 57th episode of Peculiar Case in Renal Transplant. I'm the moderator today, and Dr. Rajan will be the academic support, and he is the person instrumental in bringing all the speakers, and I'm just doing this secondary work for him. So every alternate days or most of the time, he is the moderator, and I'm just being the doing the backup work, and he is the main persons bringing all the time presenters, talking to the panelists, and convince them to be here, and I'm just grateful to him, Raj. So today we have two very interesting case presentations by two eminent institutions, one from the north, one from the down south, and we have a very good panelist because both the panelists are known to the entire audience in our country. They need a little introduction. So they are the undisputed academic giants, and their monumental contributions they are known to everyone in our country, and we are truly honored to have them with us today. And I think they are in the vanguard of research and teaching. They have produced so many nephrologists, young nephrologists, and also training them time and again. It's a great service they are doing the younger generation. So I think they have made my job easier. I'm just doing a little effortless job today because I'm not reading through their vast and illustrious bios. Because it runs in pages, especially Santosh's work. So I just and they'll insight speak for themselves so with a short introduction. I'm thankful to them. Thank you, sir, and welcome to this 57th episode of a Peculiar Case Renal Transplant. We have two presenters, young presenters. One she's presently with Adi Shakti. She is the third year of register at the CMC Vellore, and Unit 2 under Dr. Santosh. She's going to present the first case. Second case will be by Subhangini. She is the present Eisen Fellow under Dr. Shyam Bansal, sir. So without wasting time, we will just jump into. Are you ready, Adi Shakti?
Yes, sir. I'm ready.
Yeah, please share the slides and we'll go ahead.
Is everyone able to see my slides?
Yeah, fine. Make it full and just go ahead.
Good evening, everyone. I am Dr. Adi Shakti, a final year nephrology resident from CMC Vellore. Today, I'm going to present a case on a post-transplant patient. So he is a 30-year-old gentleman. His NKD was unknown. He underwent a live-related kidney transplant with father as a donor. It was an ABO incompatible transplant, father's blood group being A and his blood group being B, on 5/6/2025. Pre-transplant, his HLM, he had haplo-match. Cross-match-wise,
Dubai is building the world for
the host. Can you mute others and so that only few people can participate?
Yes, sir. Yes, sir.
Please do that. The background noise is disturbing the presenter.
Sir, shall I continue?
Yeah, please, Adi, please go.
So pre-transplant immunology, he had haplo-match, the CDC flow and negative, and even he did not have any DSAs pre-transplant. He only had a non-DSAs. So his ABO titers before the transplant was 1:32. Since it was an ABO incompatible transplant, he underwent desensitization with rituximab as well as 2 sessions of plasmapheresis. And anti-A titers on the day of surgery was 1:2/nil. Live-related renal transplant was done on 5/6/2025. Warm ischemia time 1 was 3 minutes 30 seconds. Perfusion time was 3 minutes 45 seconds. Perfusate uses Graflor, and cold ischemia time was 1 hour 3 minutes 30 seconds, and warm ischemia time 2 was 56 minutes. He had a digest stenting in C2. There were no immediate post-surgical complications, and he achieved another creat of around 1.46 milligram per deciliter on post-op day 5. Post-op day 7, he had an increase in the serum creatinine to 1.66 milligram per deciliter, and he underwent a renal biopsy for the same, which was suggestive of an antibody-mediated rejection. Hence, he received pulse steroids as well as 3 sessions of plasmapheresis with replacement IVIG. On post-op day 11, he had a febrile episode and urine culture was suggestive of CRO E. coli, and he was treated with ceftazidime avibactam with aztreonam, and he had a clearance of bacteremia was documented, and he was afebrile. He was asymptomatic almost till 1 month post-transplant in July 2025 when he presented with high-grade fever since 5 days, and his serum creatinine at presentation was 1.75 milligram per deciliter. Since he presented with high-grade fever and he had a past history of UTI and he had a DJ stent in C2, these were our differential diagnoses which we considered. First was a complicated UTI, but urine analysis had shown hematuria and pyuria, but blood and urine cultures were negative. Tropical fever, since he is from Tamil Nadu, dengue, NS1, IgM, malaria, wheal, felix, craft, all were negative. CRP also was negative and procalcitonin is mildly elevated. We also ruled out reactivation of chronic infections like TB. Chest X-ray was clear. There were no lymph nodes on examination. Bone marrow testing was also normal. CT thorax and abdomen, there were no mediastinal or abdominal lymphadenopathy. Infectious endocarditis was ruled out since 2D echo was normal. Is that an ongoing rejection? For that, DSAs were negative, and we also had planned for a renal biopsy initially. So CT also had shown graft pyelonephritis. So empirically, we treated as a UTI in spite of culture being negative. So on the day 8 of illness, he developed hematuria. So by now he has fever and hematuria, and he was actively passing clots. We did a repeat ultrasound abdomen pelvis, and that had shown bulky graft kidney with perinephric collections, and there was a diffusely thickened bladder wall, which was a new finding. So initial differential diagnosis was genitourinary tuberculosis. We sent a urine expert TBR, which was negative, and also we considered the other viral infections such as BK virus, polyoma virus nephropathy. BK virus PCR was negative, and also we considered CMV virus, but that PCR also came negative. Finally, we considered one of the rare differential diagnosis, that is adenoviral hemorrhagic nephritis. So we sent an adenoviral PCR both from the blood and the urine, and it turned out to be positive. So since he had a fever, hematuria, and he was an immunocompromised patient, in addition to reduction of the immunosuppression, we planned to give him antiviral agent, that was cidofovir. So we gave cidofovir at 60 mg IV and 300 mg intravesical instillation. The repeat test done after 1 week was persistently positive, but however, cycle threshold has increased. So lower cycle threshold means higher infection, higher cycle threshold means there is a lower infection rate. And he also received IVIG at 2 gram per kg body weight. Since he had persistent renal dysfunction, his creat was around 4, so he underwent a renal biopsy. This is the biopsy picture. We can see that this is the tubules. So I'm not able to use my laser pointer. So these are the tubules. So there is some evidence of ATI, and if you see the nuclei, there is a mosaic pattern in the nuclei, as well as there is the enlarged nuclei. And here you can even make out the intranuclear inclusions present in the tubular nuclei, in addition to the severe ATI. So the reported was there was a diffuse acute tubular injury with focal tubular necrosis, and there's occasional standard cells with viral cytoplasmic changes. At this point of time, there was no tubulointerstitial scarring, and Bankscrow was I1 T0 G0, PTC0 C4 V0, CI0 CT0 CG0 MM0 AH1 CV0 and IFTA0 and TI1. Other issues during the admission, he had a CRBSI, which was a central line related, which we treated, and also had a leukopenia. In spite of giving cidofovir, he continued to have persistent graft function. So almost 1 month after this episode, we did a repeat renal biopsy, which had shown severe tubulointerstitial scarring and severe arteriosclerosis and arterial hyalinosis. So if you see the timeline of events, 5/6/25 is the day when he got transplanted. He had achieved creat of around 1.46 on 10/6/25. By the post-op day 7, he had an ABMR, post-op day 11, a UTI, and his creatinine had come down to 1.24. In the month of July, he had a febrile episode followed by hematuria, and adenovirus PCR was positive. At that time, his creat was 2.15. By 12/7, it was 4.06, and the first renal biopsy was performed when the creat was 6.1. And after treatment, slowly his urine adenoviral PCR remained positive, but serum adenoviral PCR became negative. And after almost 1 month, we had done a second biopsy, and follow-up adenoviral PCR was negative. And this is his creatinine in the month of May when he was at a last visit, and it continues to be 4.87 milligram per deciliter. He continues to have persistent graft dysfunction. No more fever episodes, no more hematuria episodes. So in our case, the time to adenoviral infection was around 30 days. He had a clinical triad of fever, hematuria, and acute graft dysfunction as described in various case reports. The treatment, most of the infections are self-limited. In immunocompromised patients, we can use antiviral therapy for severe life-threatening manifestations. Cidofovir is a drug of choice. Ganciclovir, brincidofovir can also be used. These are the case reports, few of the case reports, wherein the earliest time of onset from the transplant was on day 8 till to almost 10 months, as noted by Gitwa et al. Most of them had hematuria, graft dysfunction and fever as the symptoms. The most common findings they have found in the biopsy reports was necrotizing granulomatous interstitial nephritis, and in one of the case reports they have even found TMA. Treatment, all of them had a reduction in the immunosuppression, and cidofovir was given in one of the in this patient in a study by Etia et al. So one patient in one of the case reports they have reported death, that is probably second to sepsis. Rest of them had a stable graft function, and around of one of them even reported persistent graft dysfunction. These are my references. Thank you.
Please unmute the slide so that we can see the discussion.
Yeah, so can we
Okay, sir. Fine.
start the discussion? Yeah.
Yeah. Okay.
So good presentation. So one or two queries. So one thing in the when initially she had a UTI episode which was treated with antibiotics. He had E. coli which responded to ceftazidime. So in second episode, he had again features like if it UTI, at this time adenovirus. Okay.
Yes, sir.
So did you give the antibiotics in this episode also, or it was only antiviral?
First, since he had a graft CT suggestive of graft pyelonephritis, empirically we had treated him with antibiotics till he developed hematuria, and then we evaluated further because he was not responding and there was no decrease in the fever. He continued to have fever spikes. So that is when we evaluated further whether we are missing any underlying viral infections for him.
No, that's fine. I'm asking in this episode when he developed hematuria and graft dysfunction, did you continue to give him antibiotics also, or you were just giving antiviral treatment?
Once the adenoviral infection was detected, then we stopped antibiotics. Then we changed over to cidofovir.
I think Sham Bantalji is asking about when he presented initially, we recovered him empirical antibiotics. That's a usual pattern. We give them IV meropenem after sending cultures and we follow up the reports. I think that's what he's asking.
My second question is, do you feel, because this is a viral infection, so basically
Okay, I'll try to send them.
okay. Of the immune system, and that is the reason this patient developed this is an opportunity sort of infection. So do you feel this was given cidofovir, and because he developed this change and graft dysfunction because of that, or whether we could have just reduced the immunosuppression and waited?
Sir, immunosuppression, we had reduced it moment he had this fever episode. But in spite of that, we also gave IVIG. He didn't respond to it.
Talking about the cidofovir because it is a nephrotoxic drug, and then how long it was used?
We have given 1 dose of cidofovir for him with an intravesical instillation because he's an immunocompromised, and there were case reports which had shown intravesical instillation also had better resolution of hematuria. So we had given him 1 dose after weighing risk versus benefits.
But IV was also given, means how many doses? One dose.
Only one dose was given.
So no, that was just an observation because this was a nephrotoxic medication and patient developed severe graft dysfunction after that, and which did not recover. And of course, this patient developed chronicity when you did the repeat biopsy. So whether the adenovirus is known to produce such sort of the graft dysfunction itself, or it is because of the medications, which because of that the patient developed this sort of graft dysfunction. So that was the query which I had in my mind. So means if you see this case, do you think you could have done anything differently in this case?
Chandras, may not rescue her.
See, I think this kind of situation is a surprise for everybody. It's a very rare thing, and I think when the hematuria came on, we knew it's not I mean, the treating physician would know that it's not a regular UTI. Otherwise, I mean, we get post-transplant infections. Ever since mycophenolate started, I think our UTIs have increased all over the country and worldwide. So the moment we have hematuria, we know we're dealing with something else. So I think the answer to that question is yes. Hematuria is the clue for something else going on, not a regular pyelonephritis, not even a very severe pyelonephritis. Yeah. And I think looking back, we have BK does not come usually so early. This comes quite early. The triad of, I think the message is if you have a UTI with sterile cultures, consider adenovirus, even though it's a rare occurrence. I think that's the message we all have to keep in mind.
Do not do it very commonly. In fact, I asked my microbiologist that me about this thing. So how commonly you do it? And I agree with you. Usually the UTI will not cause hematuria, but sometime that is why I was asking whether this patient was simultaneously given IV antibiotic also. Because of that, he improved, and adenovirus just a bystander, or it was actually pathogenic of causing this thing. That will be very difficult to tell for anyone. But I was just wondering whether there was a simultaneous administration of the IV antibiotics and the cidofovir also, and because we gave everything and this patient,
Why she's not able to send?
whether this drug or the infection itself caused the chronic changes which led to graft dysfunction, which did not improve even later on.
I think it's a viral infection itself which caused the graft dysfunction. The cidofovir could have contributed to it, but I think it was a last-ditch attempt to try and save because nothing was working. IVIG and decreased immunosuppression didn't work.
No, no. When you are dealing with a case practically, then at that time, what decisions you take, that becomes, and that is sometimes you have to decide urgently and based on the prevailing situation. So I'm not. We are just discussing that how probably we could have done something differently or no or this thing. But obviously, once you are dealing with any case, you deal according to the best what you can do to the patient with the patient.
And my patient had a biopsy-proven adenoviral nephritis. And of the case reports and the case series that I have read about, biopsy-proven adenoviral nephritis has a poor prognosis. They have more chances of chronicity. Since I had an evidence of it, probably I would say the graft dysfunction was more secondary to the sequelae of an adenoviral infection. As Sir has said, cidofovir might have contributed, but we could not withhold the treatment just because cidofovir is nephrotoxic in his case, and he responded to cidofovir, and that was a good thing that we noticed in him.
Okay. Okay. So again, the two things. One is that did you do there is any staining available for adenovirus in the graft, like for the BK virus and other, by which so adenovirus viruria was there or viremia was there. Secondly, this adenovirus with the copies means they were very high in the blood, or because I don't know what is the normal prevalence of the, like if you see BK virus or JC virus, their prevalence in the normal population is also very high. 70 to 80% people they will be seropositive for those sort of viruses. What is the prevalence? Did you do staining for adenovirus in the graft? Is there a staining available? And the copies of the adenovirus in the blood?
Regarding the first question, there is staining available, but since it is a rare disease, currently it is not available in our lab. So we had to go with the clinical correlation. Responding to the second question, yes, there is a quantitative PCR available for adenovirus, but since it's a rare disease, we have only qualitative PCR. So we had to go back to microbiology, see the this threshold, and then finally we had to infer that since it is increasing, probably he is responding.
So that is an association, most likely. It is a pathognomic or not, we are not sure, but it could be. Okay. Thank you.
Dr. Sham, immunohistochemistry is somewhat gold standard for adenovirus nephropathy. We can, in a histopathology, we can have a smudgy basophilic inclusions. But gold standard is immunohistochemistry. Most people are doing that actually, the immunohistochemistry.
And in their lab, it was not available. And the blood levels was also qualitative, not quantitative. So we don't know whether what was the value of the adenovirus in the blood. And this.
Yeah.
Okay, thank you. So,
Subhagini, I have some. What is the dose you used, Cidofovir, and what was your Santosh Bhaiya, what was the intention before using it? You wanted to use it once, a single dose, or you want to repeat it after some time? Because the dose available, it's available as 375 milligram per FI, right?
Yes. It is available as 75 per 5 ml.
Okay. So you used 300 milligram intravesical, and you said 60 milligram IV, something like that. No? What is
Based on 1 mg per kg body weight, we went to the case reports, and 1 mg per kg body weight we gave IV, and then the remaining 300 we gave intravesical, and it was put intravesically. I had to change positions every 30 minutes so that the entire bladder will have the contact with the antiviral.
Okay. The recommended
We
dose
have
is
1 or 2 case reports like Ho et al, wherein he has reported that intravesical infiltration has a better resolution in hematuria, and it is better when the patient has when the patient is refractory to IV cidofovir. Up to date, as per the recent up to date, it is showing they have told 5 mg per kg IV cidofovir.
Yeah, fine. Okay. So you used 1 milligram per kg IV, then 300 intravesical.
Intravesical.
So intravesical, what is the procedure you did? You did a triple way Foley's catheter, then like that?
Yes. Triple way Foley's catheter under sterile aseptic precautions. And no, this was instilled, and later after 1 hour of installation, he voided the urine.
Okay.
Hello.
Yes, sir.
Yes, sir. I'm able to
You
log
are ready
in.
now. Okay. So somebody, anyone people wants to contribute to this? And one more thing, you said the perfusion time is only 3 minutes 45 seconds. Soon after after trial, what is the duration you perfuse the graft? And in the slides it was showing. I think it's a typo, I think.
Check that.
So generally we do around 15 to 20 minutes perfusion. You said 3 minutes 45 seconds was the perfusion time you written.
I just cross-check that once.
Okay. Okay, nice, Adi Salim, but the right point you have made out, because the recent times we have been hearing this lecture about adenovirus. Even as a matter of fact, the recent times, last 1 decade or so, many lectures, at least in a random way, we come across this kind of a presentation by presenters, that the 3 cardinal, as you rightly said, fever, azotemia, and hematuria. And Santosh Bhai said, any sterile urine, despite patients having trouble, you have to suspect, though it is rare. See, quote unquote, he said, though it is rare, you have to at least suspect adenovirus. The very good take-home point. At least we can, though the treatment is not definite, and once we know that this burning fire is there and still basic creatinine after 1 year it's 4.87. So almost we have lost the graft almost. So at least we can, earlier identification, we can use some kind of a reduction and some kind of measures we can undertake, because one kidney is one life for our Indian patients. So this is the issue we face, and this is a very bad virus. So, and it's a mimicry of many diseases, like UTI with hemorrhagic UTI with non-sterile urine is 1 point. Second, it can mimic like a BK virus, only the biopsy can put an end. And third thing is it can mimic like a rejection. So and again, biopsy will be the determinant factor. So it's nice that time and again we present this, because to reiterate a fact that this is at least this will be thought in mind and in some cases. So thanks. Though you are presented very in a fast way, but we could catch essential points. Thank you, Adil.
One point I would like, every virus is a bad virus in transplant.
Yes, Vansal, right. But this is a great mimicker. That's why they made a point like this, a great mimicker actually. Adenovirus mimic like many things, and I think the very firm take-home message is a fever, azotemia, hematuria, sterile urine. We have to think adenovirus. I think this is a very important fact, because in a busy practice we just tend to forget everything, and this is the one we can do it. Somebody asked something. They adenovirus past infection rate 90%. Manish, you want to add something by you just
No,
type the
sir,
message.
there was discussion about the prevalence in normal population. So that I was saying, the normal population antibodies are in 70 to 90%, but PCR positivity is in 2 to 18%.
Okay. But pseudoephedrine, the cost is quite high, and we have to be very sensitive in using high hydration along with probenecid before and after, so that this can be avoided. And the recommended dose is very high, once weekly for 2 weeks, and after that you have to eat once in 2 weeks for at least 1 or 2 doses. But I think many presenters in our country, they present only 2 doses, they could achieve some results. And and you have added one more point, intravesical instillation also helps a lot. So this is another take-home point. Thanks, Adi, and thanks, Santosh Bhaiya, for.
We have had a patient with adenovirus which presented with diarrhea, enteritis,
Oh, yes,
and
sir.
some kind of mild uveitis. Then worsening graft function, hematuria, cystitis. So this combination is more suggestive of adenovirus. Enteritis.
Yeah, exactly.
We had one patient actually in MMC when I was in MMC. And it was proved by graft biopsy, immunohistochemistry, thanks to Dr. Anila. She was able to prove that it is adenovirus. The patient luckily escaped just with the reduction in the immunosuppression. And some authors believe that IVIG may help, but fortunately our patient escaped.
Sir, your patient had a eye infection with enteritis, sir.
Yeah, temporarily it's all related. Yeah, followed by cystitis, hematuria.
Fine, sir.
Thank you, Dr. Gopal Krishna. We were
You were remembering it, sir, at the beginning. Shyam was remembering where is that. So now you joined, sir.
I just joined actually. I missed out the initial presentation.
Okay, so
thank you.
that's the gist of everything. And another point she made was, necrotizing granulomatous inflammation. That is the one with the interstitial hemorrhage. That is another point. We have to take a deep biopsy to have, juxtamedullary junction to understand about all these things. So the thing is necrotizing. The word necrotizing granulomatous interstitial inflammation, nephroid. That's one thing you pointed out 2 times. That's another point. So with this, we'll move on to another one, and second case, Bhagini.
Yes, sir.
Please share your slides and go ahead.
Sir, I'm not able to share my slides. Can you share the...
Saurav? Okay, I'll do it. Okay.
Yes.
If it's not none, then I have slides. Okay.
Yes.
So meantime, we can have a discussion, because this is... Sorry, anyone wants to contribute to anything?
Why are you not able to share? Because then you have to move your slides according to.
Yes, sir. Not able to share.
The slide is visible, sir?
No, I'm also sharing. Are you sharing?
Yes, sir. Yes, sir. Can you see the slides?
Yes.
Yes, sir.
I think this is Rail sir's slides.
It's my slide. Okay. Swagni, just I'll make it a full thing, then you'll go ahead.
Yes, sir. Then I can start. Yes,
I've never used almost 2 decades ago I used PowerPoint. I'm used to only where to go and do it. Okay.
Slideshow options.
Yes. Okay. Okay. Go ahead.
So the first slide.
Yeah. Okay. Fine.
Good evening, everyone. Today I'll be
But,
presenting.
go slowly. We have a good time for us to discuss because
Yes,
this
sir,
side
sure.
is very go slowly and okay.
Sure, sir. So, good evening, everyone. I'm Dr. Shubhangini from Medanta Hospital. So, my case for today is a 63-year-old male. He is a line-related ABO incompatible allograft recipient. It was done in July 2017. Now, right now, he's also diabetic and hypertensive, and he presented with symptoms of forgetfulness since the last 3 months, headache since 2 months. There is loss of balance, and he's unable to walk without support since 15 days. Even he's not able to perform the daily living activities, dependent on his family members for everything since 15 days. He's speaking less, often incorrectly responding to the questions, repeating similar words since 10 days, and he's not recognizing his family members since the last 5 days. There is no history of any fever, cough, blurring of vision, vomiting, dysphagia, or bladder and bowel incontinence. So, next slide.
Yeah.
So, if you look at the past history, patient had ABO incompatible kidney transplant in 2017. It was the donor was wife. It was a AB2B transplant. The desensitization was done using 100 mg of rituximab, and since the titer was 1:8, he was not given any plasmapheresis. So, induction agent that we used was ATG, 3 mg per kg dose, and he was maintained on TAC, MMF, and steroid. And in his current episode, he is currently on TAC 0.5 mg and 0.75 mg, and his TAC level is around 5.9. And along with that, he's on MMF at 360 BD, along with a steroid of 7.5 mg per day. So his post-transplant course, he had a stable graft function. Currently, the baseline creatinine is around 1.4. There has been no episode of graft dysfunction or rejection. In 2022, he had graft pyelonephritis and he responded well to antibiotics. Other than that, there has been no CMV, BKV, or any other opportunistic infection. Diabetes and hypertension are well controlled. And till the current episode, it has been like from 2022 to right now, there has been an uneventful post-transplant course. So next slide. Yeah. So on examination, he had a blood pressure of 110/70, pulse rate of 82 beats per minute, respiratory rate of 20 per minute. He was conscious, but he was disoriented to time, place, and person. He's not following any verbal commands. There were no signs of neck rigidity. Even the Kernig sign was negative. And on motor examination, he had a power of 4/5 in all four limbs. And the deep tendon reflexes were 3+. Their bilateral platform, and he had gait ataxia. He was not able to walk. So next slide. So these were the initial labs. His serum creatinine had increased to 1.8, urea of 55. The electrolytes were okay: sodium of 141, potassium of 4.8, calcium of 9.6. The blood hemoglobin was also 12.5. TLC counts were normal, 6,490. There was no thrombocytopenia. The differential count also shows 85% neutrophils. The liver function tests were also normal. His diabetes was well controlled, HbA1c of 6.5, RBS of 110, and he did not have any proteinuria as well. And the TAC level at this stage was 5.9 nanogram per ml. And also the viral serology was negative for HIV 1, 2, HBsAg, and HCV. So next slide.
Moving, Swagni.
Yes, sir.
Moving. Okay, fine.
So, with all this presentation, we first referred him to the neurology, and we did a brain MRI for him. So, next slide. So, if we look at these MRI films, the first film is a T1 image in which we can see a large mass-like lesion which is appearing hypointense on T1. And this is a lesion present in the left frontal and inferior parietal lobe on the left side. And it is mainly involving the white matter, and there is no mass effect. The same lesion we can see in T2 and FLAIR images, which is appearing as hyperintense. And if we look, yes, sir.
This one, right?
Yes, sir. And if we look in this image, even the corpus, it is crossing the midline and extending into the corpus callosum as well.
This here, right?
Yes, sir. Yeah.
Okay, fine. Do you want to describe more here? Okay.
Yeah, the most important thing here is that it is a very large lesion, and it is involving only the white matter, and there is no associated mass effect or perilesional edema associated with such kind of lesion.
Any comment anyone would like to make about the diagnosis of this patient based on the lesion?
Sir, the first when you started, I thought it's a PML. That is a leukodystrophy, but I don't think it's not a diffuse one. It is a unilateral, subcortical, crossing the midline, mass-like lesions. Someone can comment, sir.
PTLD would be the lesion.
Yeah, this one another thing, maybe PTLD, right, Raj? You are correct, maybe. So in the initial presentation, I thought it will be PML.
PML is also one of the important diagnosis.
No, but I think the lesion is very focal and subcortical, large lesions. Okay.
We'll go to the
You want
next.
to give any clue, Subhagini sir and Bansal sir, you want to give any clue to us so that we can judge anything?
Sir, we'll move on to the next image. That
yeah, fine.
Yeah.
Yes. Let's see what comes.
Okay, sir, fine.
So this is the similar axial and sagittal view of the lesions. Like it is showing similar findings. We can see that this extension of the corpus callosum is present.
Yeah, here, right? This
Yes.
one. Okay.
Yes. Yeah.
And here
even
also.
in the sagittal films, yes, sir.
Yeah, so this area. This is very clearly seen. Okay, fine.
Yes.
Okay. Should I move on to another? Okay.
Yes, sir. Yeah,
fine.
So with this imaging, we have one main differential, which is PML. So we can see that the lesion was hypo intense on T1 and hyper intense on FLAIR and T2 images. Other possible differentials with this mass-like lesion could be infective causes like tuberculoma, toxoplasmosis, or nocardia. But all of this will have some ring enhancement, some perilesional edema, some mass effect. Another differential could be a primary CNS lymphoma. It is a solitary multifocal lesion, but again, it will show some contrast enhancement. Actually, in this patient, we have not done a MRI with contrast. So, if it is PML, that should actually not show enhancement if there is no other inflammation along with it. But with other lesions, we generally have contrast enhancement. The other differential could be acute demyelinating encephalitis, but that would involve both the gray matter and the white matter, and there will still be contrast enhancement. Another differential, if we go by the clinical, then patient did not have any hypertension, but PRESS is another similar looking lesion on MRI. It will be hyperintense on T1, and it will involve both the gray and white matter, and then we can have multiple sclerosis as well. But the important thing is that the location of these lesions will be mainly periventricular, and that will also have, like, it is usually described as disseminated in space and time, so it will have both contrast enhancing and non enhancing lesions. So next slide.
Yeah, fine.
Yeah. So our patient had this T1 just
back one. Okay.
Yes. So like I showed you the images, our patient mainly had T1 hypointense and T2 and FLAIR hyperintense with some diffusion restriction, and there was little to no mass effect, which like we didn't do a contrast MRI, but it should not show any contrast enhancement on MRI if it is PML. So next slide.
Yeah.
So this is the MRI report which was finally given. So it is basically a large mass-like lesion involving the left frontal lobe and involving the white matter extending into the anterior body of corpus callosum, crossing the midline. And similar lesion is also seen in the left inferior parietal lobe. That is a smaller lesion. And with the history of immunosuppression, these findings were highly suggestive of PML. And other than that, there are some other small lesions which in the white matter hyperintensities in right centrum semiovale, and some chronic multiple lacunar infarcts, and along with that generalized cerebellar atrophy. So next. So the diagnosis of PML was there on the MRI. So we proceeded with the rest of the workups. Next slide. So in the blood workup, we had seen the HIV-1 and 2 antibody test was negative. We also did a RNA PCR to confirm that was also negative. We did a CD4 plus T cell count, which was actually low. It was 115 cells only. And the toxo IgG and IgM was also negative. So we ultimately did a CSF examination. In CSF, there were the glucose was 88, which was actually less. If you compare it with the concomitant BSL, then the CSF glucose was low. The proteins were elevated, 174 milligrams per deciliter, and there were only about 2 cells and One of them was a neutrophil and the other was lymphocyte. And the ADA was normal. The CSF for gram staining, AFB, and KOH mount were all negative. So next slide. So we did a PCR-based rapid meningitis panel. All the bacterial meningitis organisms were negative, and it was also negative for CMV, enterovirus, HSV1, 2, varicella zoster virus, and HHV6, and it was also negative for cryptococcosis. The CSF was also negative for gene expert for MTB was also negative. And considering PTLD as a possibility, we also did EBV PCR both in blood and CSF, which was all negative. So next slide. So ultimately, we sent the JC virus PCR sample for the CSF, and this has come positive in our patients. So CSF is positive for JC virus. And since JC virus and BK virus can be concomitantly present, so we have also sent plasma sample for BKV DNA and JCV DNA, but the report is awaited as of now. Yes, the next slide. So we did some review of literature. So this is actually not a very reported case. So in 2005, this was one article which was published in Transplant International, in which they described the PML incidence in transplant recipients. So they reported about 24 cases, of which only 9 were in kidney transplant. And according to them, the median time of onset was around 17 months post-transplant. But most of them, in kidney transplant specifically, most of them presented after 2 years. And most of the later presentations were seen in kidney transplant recipients. So next slide.
Now from
This is another case report, case series which is published in Transplantation in 2018. So this was basically a retrospective cohort study which they did using the USRDS data. And in that also they identified about 9 individual cases among 32,757 primary kidney transplant recipients, making a cumulative incidence of 0.027% only. And they actually correlated the incidence of PML with some factors. So they found that BKV infection, pre-transplant blood transfusions, high sensitization, that is a PRA of more than 20%, or use of any anti-rejection treatment within first year was found to be significantly associated with PML. But mainly they wanted to look if any immunosuppression was relevant for causing PML, and they looked at MMF, which was not. So next slide.
Yeah.
So this is an article which was published in a neurology journal. So basically, they also looked at post-transplant PML between 1958 to 2010, and they have also found only 69 cases, of which 19 were in kidney transplant recipients. And they studied the median survival for following the onset. It was around 6.4 months. So being a mortality of about 41% at 6 months and 55% at 12 months. And they actually correlated if the survival is correlated with any of the immunosuppression that we commonly use. So there was no clear association with any of the immunosuppressive agent, and they also did not find any treatment to provide any therapeutic benefit according to their case series. So next slide. So this is the like the latest literature in accounting for incidence of PML, was recently published in 2025 in AJKD, in which it's a French study which basically looked at PML cases among the kidney transplant recipients specifically, and they have also found only about 25 cases, incidence of about 4.9 plus 100,000 person years, and they have reported that the most common clinical symptoms are mainly the motor deficits and the cognitive disorders, and along with that there can be other visual complaints like hemianopsia. And the location of most of these lesions are mainly the 47% in the frontal and the parieto occipital region. They have also found that most of these patients had prior BKV or CMV infection only, and significant exposure with belatacept, but we don't commonly use belatacept in our setting. About 8% also had received rituximab, and it has been associated with T-cell depleting induction as well. So next slide.
Yeah.
So they actually published outcomes. So among these transplant recipients who developed PML, there was about 60% mortality within the first year. there was 40% patients were actually alive with partial remission, but most of, like, about 8% of these patients suffered from graft loss. And most of these patients, about 90% of them, were treated with alone with reduction of immunosuppression, in which they discontinued the MMF and they did reduction of CNI. And one patient only developed the immune reconstitution inflammatory syndrome post restoration of immunity. And some experimental therapies like the anti PD1 and PDL1 inhibitors and interleukin 7 therapy has also been tried. So next slide. So, what the literature describes as approach to treatment of PML, the mainstay is reduction of immunosuppression, but no specific guidelines have been published regarding it. It's mostly the anecdotal case reports. So, it has been seen that in various case reports that immune reconstitution alone has been beneficial for kidney transplant recipients, and many of them have even survived after discontinuation or reduction of immunosuppression. So these are two case reports. In the first one, there is a 51-year-old female who developed PML at 5 years while on immunosuppression with cyclosporin, MMF, and steroid. And after development of PML, the MMF was stopped, followed by cyclosporin also. Dose of steroid was also reduced, and there was clinical improvement, which was noted after 1 month of withdrawal of immunosuppression. And by 6 months, the radiological improvement was also noted, and the CSF was became negative for JCV DNA, but the graft was actually lost due to rejection. And similar outcome is seen in another case report, in which also after discontinuation of the MMF and TAC, there was improvement in the symptoms and MRI lesions, but the graft was lost due to rejection. Next slide. So there are no effective treatment which are present for complete cure. Some therapies which are commonly...
Please go ahead. That's the background noise, so just go
Yes.
ahead.
So there are certain other investigational therapies which have been used. One of them is mirtazapine, which has been commonly used in patients with HIV who develop PML, cidofovir and mefloquine, but there are still no specific studies which have been done. Only case reports exist. So next slide.
Yeah.
So if we look at mirtazapine, this is a case report which was published in BMJ in 2022. So this was also in a female who developed PML 10 years following the transplant, and they actually started to use 15 milligrams of mirtazapine along with TAC and MMF withdrawal, and gradually the dose was increased up to 45 mg per day, and 5 years later the patient is doing well. So next slide. So these are all the case reports in which mirtazapine and other therapies have been used. So as we can see in kidney transplant, mirtazapine has been commonly used, and the survival rates have been good, like about 2 years to like that is there if we use mirtazapine. So next slide. Another treatment that has been used is GCSF or filgrastim. So basic principle is that it may stimulate the T cell immunity, and mainly in patients who develop PML post natalizumab, they have used this filgrastim. In kidney transplant recipients, it has not been studied specifically, but various case reports along with immunosuppression reduction, we can use filgrastim to increase the CD4 T cell count. So next slide. Another thing which we commonly use for treating BKV nephropathy is IVIG. So in patients with HIV, they have studied the use of IVIG for 5 days, and mainly low dose IVIG, and they have repeated it every 8 months, and that has also shown good results. So next slide. So there are certain emerging therapies like immune checkpoint inhibitors, and they have also not been specifically reported in transplant recipients. Another therapy is recombinant interleukin 7 therapy, but that has also not been shown to be very helpful in transplant recipients. And then upcoming is the virus specific T cell therapy. So next slide. So what have we done so far? So we have reduced the immunosuppression. We have stopped the MMF. We have reduced the CNI from 0.75, 0.5 to 0.5 and 0.25. We have actually reduced the dose to half, and we are targeting a TAC level and we are going to we have going to start mirtazapine as of now, and if the patient doesn't respond, then maybe we'll try with IVIG as well. That's it.
Thank you, Subhangi.
Yes, sir.
Saying we have encountered, at least I have encountered in my practice for the first time, the case DC virus, PML, both for the first. I don't know what is the experience of others and what else we could do for this patient.
Very, very interesting cases. No treatment, unfortunately.
It's only 1 week back, so we are still in the process of getting full thing. But the one thing is diagnosis established. We have reduced the immunosuppression, and for me, principally, or if you see theoretically, you use IVIG also in a desperate situation in patient with BK virus. So ultimately, it's a agent whether by giving this, because there is little experience in treating this disease. Probably there could be some improvement. I'm not sure about the other therapies or BCS as another thing, because that that point of view that you can also some motivation and probably reduce the risk of rejection and this and reduce the immunosuppression. Yes. So
Santosh Bhaiya?
this
No comments from my side. It's a very rare and it's a rare thing, and it's good that you're sharing so that everyone gets to at least hear of it almost firsthand. See the disease as it is going through. I think when you have a neurological situation, once you ruled out electrolyte imbalance and hypertension related and drug induced, imaging is what we look for, and mass lesions due to tuberculomas or cryptococcus or toxo, and then you've got this dreaded thing which you only hear about, and I think Belsa nailed it as soon as you showed the described it before anyone else could open their mouth. I
Yes,
think
sir.
that was very very good of him to pick it up. Dreaded complication.
Sir, don't feel that because I'm operating a slide, I didn't see it through the slides, just here.
No, not at all, not at all. I know it because of your.
She was fumbling with slides, so she asked to help and downloaded quickly.
Yes.
When the other presentation was going on, I
Thank you,
just
sir.
downloaded. And
Yeah.
very nice presentation. Excellent presentation, because you started with presentation and went through and insinuated with some findings of literature. This nothing else. No, this is we learned a lot today from this case. We learned a lot actually.
Well said,
Because-
Miss.
Yeah, Raj Bhaiya, you
Yeah,
may
yeah, sir.
anything you want to say?
Just to add that it's a very good presentation, sir. It's a very completely new to us. Actually, we haven't seen, at least I haven't seen that kind of case. But interestingly, the T2 weighted images and showing the hyper intensity mass like lesions, there are many DDs are there from what I understood from previous case experience. One is PTLD, that should be a mass effect, and crossing the midline is also very characteristic of PTLD. And other important differentials is the CNI induced press that can present a similar way.
Yes,
I've
sir.
seen a patient with that one. And of course, your toxoplasma and nocardia, aspergillosis. I've seen a patient presenting similarly, but CSF picked up aspergillus. So quite a lot of DDs, and the main important thing there is you have to see the mass effect and surrounding edema. Edema is more characteristic of PTLD, and even glioblastoma multifamily can present like that actually. So CSF showing a PCR JC virus is pathognomic, and it is completely puts your diagnosis into the PML. And what I suggest, it should be monitored every 1 or 2 months with the MRI, so that
Yes.
the lesion, whether its lesion is
Yeah.
progressing, and
Yes, sir.
the therapy as you have as you enumerated, only reduction of immunosuppression, stoppage of antimetabolites, and reduction of tacrolimus with mirtazapine. And IVIG, I don't think it has a role. And immune checkpoint inhibitors, it is promising, very much promising, but the risk of rejection is there with immune checkpoint inhibitors. So, good job, and we have learned a lot. As Sir said, it is a very interesting case, sir. Thank you very much, sir. Thank you.
Yes. Thank you, sir.
Anyone who wants to contribute from any experience from the South? There are some people inside. Okay, so you started off with a good presentation, and you made up good points. Raj has summed up so nicely. And press is having T1 in hyper intense. You are, in your case, T2 is a hypo intense with the flare intense hyper intense. That's a very differentiating. And Raj's point was well taken. In the surrounding edema is not of here, and this is the PTLD and other mass. And you said the presentation of PML is like a motor deficit, and you in your presentation you clearly shown it's a ataxia, gait, and a plantar was extensor, and DTR was 3+. So mostly of motor dysfunction, and it gradually worsened. And so, and you said about the treatment also, there is nothing. Once you diagnose 60% mortality within 1 year, and one of slides you showed there is no relation to immunosuppression. Despite reduction in immunosuppression, no way you can arrest the progression. And immune checkpoint, as Raj said, there is no role, and very costly also. So that drives the reference. So all these things winds up that it's bad for the patient. And we learned at least one entity is there like this. We should thank you and Bansal sir for bringing up this, and because many people would accept after the completion, when the halfway through you made it, and we had learned a lot actually.
Yes, thank you.
So, I think we finished in time, and because we are until Raj and I should go there for the cadaver. And sir, NGK sir, left.
Yeah, yes, I'm there.
Please, sir.
We have not come across. It's very scary.
It looks scary, fine, sir. At least a patient should die with the diagnosis, sir. That's one way we should learn in life. At least we know what is what, and can put
the flip side of transplant is quite scary. And actually, belatacept is more associated with the PML, and I vaguely remember to have read that way.
Yes.
Belatacept, both lymphomas and PTLD as well as PML. We have come across quite a good number of CNS lesions in our transplant recipients, mostly infections.
Yes, sir.
Very few PTLD, aspergilloma and cryptococcal meningitis.
Yes, sir.
And fungal infections.
Particle abscess also. And another point you made was is a frontoparietal lesions, right? That's a very important.
Yes.
With the corpus callosal involvement. I think we should keep remembering this in our mind so that we can put it in the next differentials. So thanks for the panelists, Shyam sir and Santosh, and both speakers, and Adi Shakti and Subhagni. I think the lesson we learned today is I think we should check before 1 hour a slide, operational everything, and sit where she was very stressed actually, right?
Yes, sir, because I could not share my slides, so I was not
Well, so that's not, you worked the case very well and made the good flow of the case. All the differential.
The presentation was excellent. I should congratulate you for this, and nice, so nice.
Thank you.
And Adi and
very nice.
she left.